My name is Gilles Vienneau. I'm Executive Director of La Société Santé Mieux-être en français du Nouveau-Brunswick. I'm here as the moderator, as a traffic cop. It's very captivating to finally be able to talk about this project, which has been boiling quietly for the last 15 years, I would say. So it was told, the session is going to be in English. We invite, if you have comments or questions, to ask them in the language of your choice. There's interpretation, traduction simultanée available. So I invite you to use the tools that are at your disposal. So to start with, we have a small poll that would like you to answer. With the poll is going to be showing up right on your screen, and would like you to identify your profile or choose a profile that best describes your role within the health and or social services system. So if the poll could be shown on the screen, please, because I don't see it here. There it is. Please choose a profile that best describes your role within the health and social service system. If you're an executive, manager, workforce, professional, policymaker, community, patient, client. So we can make up what the profile of our crowd is today. If you have to think hard about it, it's a bad sign. It's still coming in, trickling in. Well, I think with 76%, we had a pretty good idea of who we're dealing with. So 9% of executive, 31% of managers, 11% workforce professional, 0% policy government, 4% community patient, 9% a researcher, and 0% student. And the bulk is 36% French language network. So oh, it's still trickling in. But anyway, well, so there are your results. I've got to close that down myself. So why are we here today? Why are we talking about a recognition program? Why are we talking about a standard in official languages? Well, to make a long story short, it all started in 2000, well, actually in the 90s, when the first study from la Fédération des Communautés Francophones Acadiennes, FCFA, came out. And it showed that there was over 55 to 60% of Francophones across the country that were not receiving health services in their language. And that was an observation that was made. And of course, we wanted to tackle that problem. We wanted to find a way structurally where we could find solutions. And we knew that we had to get to work, and it was going to be a long haul. So at first, what we did is we researched the concept. And curiously enough, we found out that it's in the United States are really a leader in that field, because they put together an Office of Minority Health, which is a distinct secretariat from the Ministry of Health and Department of Health. And their job is to make sure that all patients receiving health services in the United States are able to receive service in their language, mostly on the West Coast with East Asian, and on the East Coast, it's mostly people from Latin America. So they adapt their services, they adapt the place of service, they find translators. Of course, the official language of the States is English, but they are very capable of serving those people, and the service is very culturally sensitive. So that was our first find, it sort of took us on a path where we studied a bit more about what was going on in the country. And sorry, this comes up again, where we went out on the West Coast and in Western Canada, and found out that there was lots of adaptation for the First Nation communities in various state of development, but nothing compared to what we were looking for, which was to try to find a way to encourage service providers to offer more services in French, primarily in primary care, but also in any other, all throughout the continuum of the health continuum. And we wanted to stay away from what we've always been sort of perceived by the majority is where we would tell people, well, we have a right to that service. We knew that it was not going to fly very high with managers and policymakers and people that have to take very difficult and numerous decisions in a day. And language for them is not always the first most important issue. So we started talking about services in your own language as a quality of service and as part of a service that is secure. So mainly on communication. So it was a question on how does the patient can communicate with his provider, and how does the provider can communicate with the patient in such a way that it can be improved, and eventually with a team approach being able to at least guide the patient throughout the system in his language. So that's where the concept of a standard came together. And that's when we approached Accreditation Canada at that time, which was Accreditation Canada alone. HSO was not created yet. And we started having discussions with them. I think the very first discussions took place in 2013. So that's almost 10 years ago. And it evolved with the publication of the standard in 2018. And right now, Accreditation Canada is developing the OLRP, the official language RP recognition program. Always used to French in there, and the Health Network of Southern Ontario also developed a tool which is called eQUITY Link, and those two tools together will help policymakers, decision makers, managers to register for the OLRP program, make a self-assessment, find out where they're at in their capacity of offering the service in language of choice, and then progress as it goes along. So basically, that's a bit of the story. That's all behind why we're here today, and we're very proud to have teamed up and collaborated with Accreditation Canada, with HSO, who developed the standard itself. I was lucky enough to be part of the whole process from the very beginning up to now. And so that's why I think it's very important for us to recognize that there was lots of effort put behind that work. It's a team effort, and la Société Santé en Français, Agrément Canada, Accreditation Canada, and all the other partners were very, very much involved. And I have to admit, I think we're a little ahead of what I would have thought 10 years ago. I know it's going to be a long haul, but I think that actually right now we're right in the thick of it, and it's actually a fun ride. Right now, what I'll do is introduce our panelists, because you won't hear me talking all the time. We have 3 panelists. First is Isabelle Jarrin. Isabelle Jarrin is from Manitoba. She's the Manager of Patient Safety with the Winnipeg Regional Health Authority, WRHA, and she's an Accreditation Canada surveyor. Hi, Isabelle. We also have Étienne O'Connor, who is Director of Operation for Accreditation Canada. Étienne has been partnering with us for a long time. Bonjour, Étienne.
Bonjour.
And finally, last but not least, we have Antoine Désilets, who is the Executive Director of la Société Santé en Français.
Bonjour, Gilles.
Bonjour. Bonjour, Antoine. So welcome to all of you. And we will hear from you guys all throughout the presentations. And I will sometimes intervene. Sometimes we'll take questions from the public. So I invite you to be as bright as you always been throughout this session. We're going to go for the second poll before we get going in with the discussion itself. And the second poll will soon appear on your screen. And it's asking you about what barriers does your organization face regarding equitable access to service in official languages or any other language? You can check more than one option. Is it knowledge, skill, tools, current capacity, readiness to address language accessibility, cost, or other? So there we go. There's 72 people on the house today. For anyone who's clicked other, you can also indicate in the chat box how or what you consider other. Come on, we're not with an election in the United States. You have to vote, people. Seems like we're stuck at 45 there. 46. Okay, well, so here are the results. 54% knowledge, skills, and tools. 72% capacity. 35% readiness to address language accessibility. Cost, 35%. Others. And in others, we have lack of health purveyors, francophone health purveyors to offer services. So there we are. So very interesting. I think that this is the most interesting part right now. We'll ask the people to share what they think about various topics here. So my first question is to Isabelle. When you're reviewing the audience response as a service provider or as a surveyor, what are your thoughts about the current challenge that we have in the country as far as this goes?
Gilles. Yes, I would agree that we locally face similar challenges of availability of staff who are bilingual, as well as the training that's available for them to support. So here in Manitoba, we're not officially a bilingual province. I think, Gilles, that goes to your province in Nouveau-Brunswick. But we do have a mandate to offer services in French. And just to give you a bit of context, approximately 9% of the population here in Manitoba are bilingual. They can speak both English and French, with about 3.5% being French as a first language, their mother tongue. The other context for us locally is that we have seen more than 2,000 French-speaking immigrants coming to Manitoba since 2015. And so that, of course, expands the needs that we have for consumers of health services, as well as potentially it adds to our pool of French-speaking staff. So to talk about the challenges that we face locally, training has been identified as a challenge. We have as I mentioned, the health authorities here in Manitoba have a requirement to offer French services, and so part of that includes having a support network. So having the training, approved training courses that are available, as well as guides or translation tools that are available to staff when they're on the job in the moment, providing services in French. And so one of the things that's come out is the commitment, the time commitment that it takes for people to attend their French language classes. You're juggling being a direct care provider or working in healthcare, which is, I'm sure across the country, people are working a lot of overtime. And so you have to balance that with your work life, home life, as well as attending the classes. And it's not just attending classes, as we know with learning another language, it's also practicing. So we've heard that the training can be a challenge for staff. The other piece that we have is that working in healthcare, while some services, are very Monday to Friday and very time limited timeframes, others are 24/7. And so then you may have designated bilingual positions like we do, as well as staff who are hired into those positions, but they may not always be working in the moment that you have a need for French language service. So I think that's another challenge that direct care providers face when they're trying to offer French language services. I think another challenge is promoting the awareness of actually making an offer for French language services. Myself being bilingual, growing up, we'd be out with our family speaking in French, and people would hear us speak French and they'd say, "Oh, I'm so sorry, I don't speak French." And, they would, and then we'd be like, "Oh, that's okay." And that was, at a restaurant or something. But when you think about being in receiving healthcare services, when we hear people, clients and their families speaking in French or another language, it's about that active offer to say, "May I help you? Would you like services in French or in another language?" And so really that awareness to make that active offer. I think that's another challenge, that, getting that culture alive and well in our organizations is important. And then, yeah, I have a couple other thoughts, but I'll leave those for after, because I think they'll go with the next question. But yes,
well, thanks very much.
To you.
Thanks you very much. I think that it really starts up our conversation very, very well. Thank you for your comments. Now I'll shift to Étienne. Étienne, as an accreditation service provider supporting clients in their continuous quality improvement journey, what are you hearing? Any comments or thoughts on the current challenges?
Merci. Thank you, Gilles. And this is not an easy question or simple one to answer. I think Jennifer Zelmer alluded to a few things earlier, but it's a very important one. One that's been present, I would say. I think you commented on. It's been present for years, and recently got accentuated because of COVID. So we're talking about equity gaps, and this equity gap because of COVID factors in many different topics. So today I'll focus mainly on the topic of our discussion in the panel, specifically right on equity, access, and we're specifically talking about language. And we're also connecting this to inclusion as well, because there's a component of inclusion connected to inclusiveness connected to this. And the best way I'd like to start is to first trigger some reflections and some information for the collective group, but also in the Q&A session also, is to start with some research and data, and then I'll flow into what we heard within stakeholders across Canada. And as you'll hear, there's a lot of common needs for all linguistic minority groups, and I want to emphasize, from a patient safety and quality care perspective, there's this collective approach for all linguistic minority groups that we can all gain collectively together from this. So let me start first with a bit of research. So we did some research as well at HSO and Accreditation Canada on this journey. And if we look at what's out there, if we look at equity, access, language, there's sparse research out there in Canada on equity gaps of linguistic minority groups or marginalized groups when we try to connect it to health quality and safety outcomes. However, that being said, earlier this year, some of you may have been made aware of this research, but earlier this spring, Dr. Amy Sue, lead research from Ottawa-Bruyère Research Institute in Ottawa, published a paper that did an environmental scan, but also a lit review, PubMed, and all these other databases to pull in the research up to date on these topics of equity, service quality, patient safety, and specifically connecting it to minority linguistic groups. And so this research is inclusive of Canada's official bilingual languages, so English, French, but also covers First Nations, Métis, and Inuit communities, and also, as Isabelle pointed out, the newcomers into Canada, so immigrants and refugees. So the research notes that there's, first of all, a great variability across Canada, and we're a very diverse population. And when we're looking at service offered in official languages or language of choice, there's a lot of variability across Canada. But where it gets interesting is when we look at that research, and there seems to infer a few outcomes specific to the linguistic minorities and minority groups and their interactions to the healthcare system. So it seems to point that the minority groups are more likely to experience adverse outcomes, more likely to experience a poor experience overall, and consequently make more complaints. More likely as well to experience poor patient assessments. So we're talking also misdiagnosis, delayed treatment, or inappropriate treatments. And consequently, more likely to have lower confidence in the healthcare encounters. For that last point, I just want us to think what that means. That speaks to the word inclusiveness, inclusion, how people feel when they interact with the healthcare system. The other interesting point that was published in this research, and for us to be aware when we're thinking about all of this, is if one belongs to more than one minority group, it seems to have multiplicative negative effects on the individual health outcomes and patient safety. So we think what this means, for example, if access challenges, they can be accentuated in vulnerable populations in addition to language. They can also be accentuated with the elderly. So there's a compound effect on this, the healthcare outcomes and patient safety for these populations. And it certainly has been accentuated, certainly with the COVID-19 health human resource shortages that have been mentioned so far. So this recent literature review seems to point towards an increase for risk and quality and patient safety when a person from a minority linguistic group is interacting, pardon me, with health or social services in Canada. And I think Jennifer Zelmer also eloquently spoke to this a few minutes ago in her panel presentation. But the other thing I'd like to think through is in addition to that variation across Canada, how does the landscape currently look like for linguistic minority groups across Canada? What did we hear? So I feel what gets interesting is when we review another piece of data. So if we look, for instance, last year, 2021 Canadian census, and we look at it from a lens of minority languages across Canada, if we look first at the Francophone population, for starters, we can appreciate that approximately 21% of Canadians identify French as their first language. That's the average. But if we dig deeper and we look at variation, if we look at Quebec, we hit at 82% that identify French as their first language. And on the pole opposite, there's a few, but I'm going to pick on one province. If we look at British Columbia, 1% identify French as their mother tongue or first language. So there is variation across the country about French languages as being the primary language of choice. Where it gets interesting too is if we think outside the box too about language and access. If we look at the allophone, so that means those that do not speak French or English as their first language. The recent census shows that, and I'm going to pick on the two urban centers, Vancouver and Toronto, 26 to 28% of the populations do not identify French or English as their first language of choice. So we're talking about Mandarin, Punjabi, Spanish, Arabic, and many other languages. And that number's on the rise. And I think, Isabelle, you pointed out to what I was going to add to that is in discussions with other provinces and ministries, they're also pointing that there's likely going to be a new shift coming that we're to expect outside of those big cities and they're in the more of the rural areas. And it's connected to the health human resource challenges that we're all living. So there, as we all know, and we're calling out, there's it's the other pandemic really is about the staff health human resource shortage across Canada, and various jurisdictions have different recruitment and retention strategies to address that. A few are using out-of-country recruitment strategies to recruit talent from overseas that when they come in as immigrants, come in with their families and have a language. And so the question is, how do we support that new population coming in their language of choice? Is an open-ended question that ministries and regions are starting to ask themselves. The other one that I want to add, and this is just adding on, I attended a conference last week, and I want to speak to First Nations, Métis, and Inuit populations. And the presentation was done by Addie Price, which is the VP Indigenous in Interior Health, BC. And it was presented last week at the Canadian College Health Leaders local chapter event. And her previous role, she worked in Aboriginal Affairs and the federal government. But what she shared was a bit of an interesting stat for us to reflect as well when you think about language. And we're going to connect the dots to the research. In Canada, we have about 630 reserves currently. And within those, there's approximately 50 different dialects or languages. And what she shared is that the main gap for access to quality care, the biggest risk in her viewpoint was language. And that in her viewpoint, in addition to the language identifier, the second compounding factor was age. So the elderly population, in addition to language, was also a big challenge that they're perceiving as far as access to care services that affects quality and patient safety issues. So if we connect back to the research that pointed to the story seems to align there. So if we pause for a minute and we take a step back, Gilles, and what we're seeing and hearing is really that the data shows that there's a lot of variation in Canada on access to care and services in both official languages. But there's also this very important concept to be aware for the language minority groups, knowing that the research seems to demonstrate that for all these groups, there's a higher incidence or odds of risks to poorer quality, higher incidence risks for patient safety issues to come, and poor outcomes or experiences that they live. So we're hearing that theme and it's very popularly themed that wherever he calls it a different acronym idea, but essentially equity, diversity, inclusion, and access. Everybody's talking about that these days. So it's now part of everybody's agenda, part of everybody's strategic plan. So it's an important concept that needs to be discussed and addressed. But I want to link in, and I'll close in on this, and I'll elaborate more on the gaps later. I think that's another thing to discuss, is the current challenges, but we need to be realistic too. We're hearing, and I think that's been called out in this conference a few times by many, is that health human resources is by far the biggest issue that everybody's living with. Right? I'm trying to address the health human shortages on both supporting current operations and at the same time supporting the transformation that needs to happen. So we do need to transform. So in the midst of those two reality checks of staff shortages, how do we move forward together to address this very important? And that's the big question, I think, and I'll keep my comments to the other question to elaborate further on the barriers to how to work together on that. But thank you, Gilles, for asking the question.
Well, thank you for a very elaborate answer, and I appreciate it, certainly. Now, Antoine, what about you? As a representative of a national organization supporting access to French language, health, social, and community services for minority Francophone and Acadian communities across the country, what is your perspective on the barriers and the challenges that we face?
Thank you, Gilles. Well, first of all, I want to react on the survey result that we showed everyone. It was very clear that I think it was 77%. The issue of skills, knowledge, and tools are needed. More than half of the responders mentioned this, and this is exciting because that's exactly the type of work that we try to promote within SSF with the tools like Equity Link and support of the official languages recognition program. But the other important thing was capacity, what I think was the #1 issue that people have faced. And my first question was to wonder, why is capacity an issue? Since people usually live where they work, in an area where people speak French, you would assume that there are French-speaking health professionals available to serve that population. It's the idea that if there's a need, there's probably a capacity, but this capacity might remain untapped. And I wonder if the capacity is related to the general situation of healthcare in Canada right now, or very specifically to linguistic capacity. But let's look at the bigger picture and what general barriers exist for communities, and how these barriers, according to SSF, like what we see is the impact and consequences of these barriers on their healthcare. The first thing I want to get up right out of the gate is that language is often tied to culture, and I think these two cannot be dissociated. For most community, their language is cannot be separated from their culture. Culture is known to be a health determinant, and culture is known to be directly related to the health outcomes of a specific population. In a more precise way, it's belonging to a culture that is not the majority's culture, or a culture for whose the system is not designed to serve, that leads to poorer health outcome. And I really want to tie culture and language, because for me, those are two sides of the same coin. Gilles mentioned an important concept that we hear often in healthcare, is that we don't have a right to health services in French in Canada. But there is a right that we do have, and that every single person in Canada has, and this is a right to quality care. And this is a right that's enshrined partly in the Canadian health law, la loi canadienne sur la santé. Sorry. Health Act. Thank you very much, Gilles. And it's a concept. The right to quality care is a concept that's been mentioned both at the provincial, at the national level, and at the international level. And it's as a basic human rights, and we should strive as a modern, rich, wealthy society to provide the best quality care to everyone that we can. Extensive documentation and research shows that linguistic barriers. So what I mean by linguistic barriers is when there's a mismatch between the language spoken by the health professional and the person receiving the health service. Extensive documentation and research show that it has a negative impact on 3 very important aspects of healthcare. The first one is the quality of care. So language barriers affect quality of care. It leads to poorer exams. It leads to poorer diagnostics. It leads to less information being shared with patients. It sets limit on informed consent in some very stressful situations. It impacts also security of care. So if you're exposed to linguistic barriers, you're more likely to suffer from incidents related to poor communication within a health system. Research shows you're twice as likely to be readmitted to a hospital after being discharged. It shows that you're less likely to properly follow your medication, which ultimately in itself leads to other health complications. And the third impact would be continuity of care. So when services are offered in some areas of the country, services exist in French, but when they're offered partially, it creates a patchwork approach to healthcare instead of a cohesive system. And I think that's, Étienne mentioned it, it's how behavior is affected by the experience lived by interacting with the health system. Étienne mentioned that people lose trust in the healthcare system. Well, what we see within the Francophone populations, and I assume we'll see it in every other minority groups in Canada, is that through their lived experience, people are less likely to seek out health services. And this, as a society, is a very big issue that we need to fix, because if people have bad experiences when they interact with healthcare, and it leads to them to using less healthcare, they'll be in poorer health, which then just compounds the effect. And it's sort of it's a cycle that we need to find a way to break. One thing I want to mention, and that's something that I think I heard in several of the comments so far, is the notion that my point is the following: translating documents, making sure everything is available in all the languages. It's not an adaptation of health services, it's a translation. And what I mean by this is that when we think about different communities, and I think the experience we have as a Francophone community living in a minority setting, is that if you just translate, you're missing all the direct lived experience of these people. You need to do proper adaptation of tools, of documentation, of research. You need to really look into what the lived experience of these people are and really take a population health view on it. It was mentioned that Étienne mentioned there's a lot of people who don't speak French or English as a mother tongue in Canada, and I think in the way we organize our health systems, I think for these people the challenge is greater. I'm going to focus specifically for Francophone immigrants in Canada coming from French-speaking countries. Since French is often not their first official language, it's not their mother tongue, but it is often their first official language spoken, which is I'm not going to get into the census, but there's a very clear distinction here. French for many of these people may not be the best quality of care that they will receive, but it will be the way to lesser harm in accessing healthcare. Using English would be worse if they speak it less. And so we sort of need to see improving quality, but also delivering services that do the less harm for these people. And I hope build on our capacity that we've been building across Canada to provide health services in more than one languages. I think official languages communities such as Francophone in a minority setting, we have a role to be the icebreaker of our health system, to really build this capacity to provide services in other languages that is not the language of the majority. And I think this in itself offers big potential to improve equity, diversity, and inclusion within healthcare in Canada. It's not necessarily fair that this fight needs to be had. You would assume that with population health vision, people would just, that fight wouldn't need to be had because it's so self-evident that we need to serve people with the best quality care we can. So it's not a fair fight, but I think the fight we're doing is one of more fairness for all in healthcare. Thank you.
And Antoine, what do you make of the comments that we hear quite often? Well, aren't all Francophone bilingual in this country?
I mean, I laugh. I'll first scoff a little bit at this one, but no, not like we can be like, clearly we're all bilingual here. And I think it's time, it's perhaps interesting to know that we're 4 French speakers all speaking in English today around the panel. I appreciate everyone going through this effort. I think that healthcare is such a specialized vocabulary. It's such when you seek out healthcare, you're not in a position of strength. You're often in a position of vulnerability. It puts you in an environment where even if 98% of Canadians have used the health system in the last year, it doesn't mean we're all experts in how it works, and it's often a destabilizing environment for most of us, regardless of language spoken. And so when you add a very specific vocabulary with a stressful impact that's often emotionally charged, with a context that you're not used to be in, it really creates a huge potential for miscommunication. A lot of research show that even when there's no linguistic barriers, people remember between 60 and 70% of what was told by their health professionals after they leave the office. Well, when you add on top of this linguistic issues, like it's very likely to people francophones, when they seek out health services, or any person who has the linguistic barriers, come out not knowing less than half of the information that they should have gathered for this consultation. So I don't think we can say that we're all bilingual. I think we may be bilingual when we go to the grocery store, but we're not all bilingual when it means accessing healthcare.
Well, thank you very much, because it's a nice intro to my next questions to you guys, and maybe we can start with Étienne. How does language accessibility fit in a broader notion of EDI, equity, diversity, and inclusion?
Thanks, Gilles. Well, I think I did kind of allude to that, but I'll piggyback on Antoine's comment, and to make it even more complex, because unfortunately things are not as simple as that in life. To piggyback on your comment, Antoine, is if it would be just as simple as a straightforward language interaction with the healthcare provider, there's compounding factors to factor in. There's beyond the linguistic approach, there's the subcategory, which could be vulnerable populations. The elders are another one, right? So there's multiple things to factor in, and they all, at the end of the day, point to increased risk of misunderstanding or not following and understanding. So Antoine, you did a really good job, I think, pointing, but I just want to add to your comment to say that in addition to the complexity, other factors also work against understanding to make it more complex, if you wish. So that aspect also accentuates the issue that we need to go back to the basics to make sure that the person sitting on the receiving of the care or services has all the best chances to understanding it correctly. And from a people-centered care approach, also be inclusive of family-centered people around, not just the individual, but the people around that person receiving care. So sorry, Gilles, I just wanted to add that layer, improvising here a little bit, but back to the EDI kind of comment. Absolutely, when we're thinking about gaps, equity gaps, improving access, being more inclusive, these are all really, really important facets that, as I mentioned earlier, were part of the challenge before. And unfortunately, now they've been accentuated. And I think Jennifer Zelmer mentioned that in her talk earlier, is that what the challenge was now is even more acute. So it just points out the gaps of equity are increasing now. Because of not just the COVID situation, but also the challenges ahead in the entire workforce of how we're kind of structured from a staffing capacity to maintain services, but also transform, because we all need to transform. So absolutely, this I think this is a good time for the whole we call it equity, different acronyms, IDEA or inclusivity, equity, access, all these acronyms. 5-10 years ago would have been very difficult to move ahead, but now I think it's a hot topic. Everybody's talking about this, so I think it's a really important one as well. So I think the timing is right. So I just want to close on that. The timing is right.
Yeah, and of course demographics are there right in our face all the time. What about you, Isabelle? What would you? How do you consider language accessibility? How does it fit in the broader notion of equity, diversity, and inclusion?
So I'm thinking about, how we plan to offer those services, right? And I think from a health delivery organization, it's about the strategic planning that starts there, and it's about being really purposeful and moving towards having French language services being available, as well as other interpretation services available as well. And so I think about, I'm going to steer it a bit and bring it to the official language recognition program, which really serves as a COD, like it serves as a strategic roadmap. Thank you for identifying services, really evaluating yourself as an or not self, but the organization evaluates its services, the planning, and then it looks to see where there might be potential gaps. So I think that's from a planning perspective, it's very helpful. As a surveyor, I had an opportunity to do 2 pilot surveys of the official languages standards, and it was really evident that that was what it assisted those organizations to do. And also in my organization, I see that it's that's what's happening, right? So there's that planning and that strategic planning, which then sets out the framework as well as the expectation that we're going to offer these services. And then I think in terms of equity, the equity lens and the diversity lens, it's also taking that into consideration and inviting service users to come and use the services and then request for what they might need. So I think that's how I see that equity lens being supported, if you will. And because I think Etienne, you mentioned it, is how do we actually live it, right? We can say we're doing equity, diversity, inclusion, but how do we really do it? And so I see that as being the way we achieve that.
Thanks. And lastly, but not least, Antoine, what about the SSF's perspective on this?
Yeah, equity and healthcare are so linked with each other. And I think I really want to make a link with Jennifer Zellmer's presentation earlier. I really believe a different paradigm on health is needed, a different vision and a way to see it. So I'll get to equity, but like, let's just, what is health, right? Health is definitely more than a care system. Health, I think health is a social resource that we as a collectivity, as a nation, we invest in. But it's a form of wealth we can't just get at, it's a form of wealth that we can only be built by careful planning and thoughtful behavior, both from a government level, an individual level, and a social level. I think when we see health care as a series of services, we focus on the band-aid part of the healthcare. So really just the fixing problems. But despite the billions of dollars we invest in healthcare in Canada every year, like we don't see a clear impact on population health. We know that more than 80% of one's health depends on their behavior, their environment, and not the care that they receive. And I think this really suggests a different view, frame on how we see population health and what we should focus on. So instead of focusing on health services, focusing on health outcomes would help us see what do we do that works and what do we do that doesn't work for which population and in what way it doesn't work. I was trying to find a way to picture this situation. It's essentially, imagine you get a bunch of people and you ask them to do a road trip between Ottawa and Winnipeg. It's a long road trip, right? Our current system is being like, well, we're going to give you a certain amount of gas to go as far as we can, and then we hope that you're going to get there. And then, but everyone has a different car. Somebody might have a small sedan. Somebody might have an SUV. Somebody might have a car that has a bunch of issues, a missing wheel, whatever. Unless we look at their very specific context from a population point of view, if we only look at the service side of things, we're always going to end up having inequity in the results because we don't look at the general. So basically my answer to you, Gilles, is we need to change the way we see healthcare to improve equity. I think a vision on population health is absolutely needed. We need to put more principles of social responsibility in health within our systems. I think the focus on care comes because care, or the amount of services that is given, it's something that's very visible. It's something that feels very immediate, and it's something that's very short term. And so we can say we help X amount of people this year. And I think this short-term vision is probably one thing that we need to find a way to change. And to go back to the official language recognition program, I think a lot of the principles that are in it are about promoting a longer-term vision and focusing on the health outcomes rather than health actions. So I think I'll stop there for now. I've got a lot more to say.
Okay, and what about active offer in that equation?
Well, active offer is just a way to provide the service. So it's an important strategy that needs to be implemented. And active offer aims to, I'll go back to my previous point, people self-censor based on their experience. So we know the recent consultation made by Health Canada has shown that people out west are half as likely to even ask if health services are available in French in their province compared to Atlantic provinces. And it's not because people care less about their healthcare, it's because they've been shown that if they ask, they expose themselves to either no answer or a negative reaction. So I think people generally self-censor. They adapt their behavior to follow the path of least resistance, and ask. Healthcare is a path with a lot of resistance built in. When you think about active offer, well, it's based on the principle of population health. You're gonna assess what the real needs of your population are and provide services in a way that meets those needs. One of those needs is services that are available in French. If people won't necessarily ask them themselves, they need to be actively offered. They need to be in people's face, so that barrier, that path of least resistance, can include having access to services in French when those are available. So I think it's absolutely essential, and I think the principle, just introducing active offer for French people, then makes introducing active offer for a whole bunch of linguistic groups way more possible if we've done the first step. And I think active offer is a successful strategy that has shown that works, and that should work for all different cultural and linguistic groups in Canada.
Thanks. It's very, very interesting, very entertaining. Next question, and we'll start this time with Étienne. How can health and social service organizations develop their capacity to offer quality, equitable services to address the risk related to language barriers? What's the best way? What's the path of least resistance?
Yeah, I think if we would all have the magic bullet here, a lot of people would have their job well done. But I think it's a very good question, Gilles, and I think many leaders are reflecting on this. As I mentioned earlier, health leaders across Canada had the opportunity this year to connect with many, are facing many competing priorities with limited health human resources, and they're into tough situations to make decisions on priorities, which initiatives to prioritize and how to approach things. I think earlier an example, and I think a question was raised to Jennifer Zelmer about the politics of red tape that we're all living, that sometimes inhibits innovation and scaling. So it's a really good question, and I'm going to connect it to, I think, our learnings when we went through the reflection process on the program development on our end. As many may know, the Health Standards Organization, or HSO, as Gilles alluded to, developed the national standard for access to care services in both official languages in 2018. Pardon me. And our mandate and role is really to support all health and social organizations in their journey for quality improvement and patient safety, and using our programs for levers for change, really to improve and provide safer care and a healthier world. That's our vision. When Accreditation Canada received the standard from HSO in 2018, we had some reflections to do. We had to reflect on the approach. And it was not an easy task, because what we've all mentioned, and I think through the poll just very well outlines what we scanned as well, trying to identify what are the barriers, what are the current barriers, and what are the future barriers coming up on such services that could enable, as like the lever for change, to move this forward. So Consequently, what we've done over the last few years is really to look at a framework of a program that could address those barriers. I think if we look back at the poll, it's not very different than what we had scanned in the last few years in the external environment of what are the perceived barriers for such programs. So when and the couple of themes that we've I'm going to just connect, and they're all similar, is we mentioned the bureaucracy, the red tape, the politics that change every 4 years or sometimes sooner than 4 years. So the top-down approach, alluding to the top-down approach, is sometimes often perceived as a barrier to have innovation from the bottom up. The other barrier that we've noticed or heard about is, I think it's mentioned in the poll, is how to simply, the level of maturity really varies across Canada on the current state of affairs for at the local level of service providers. And so how can it be easy knowing that they are very busy? How can we simplify, make it easy from perhaps a bottom-up approach for organizations to move forward in this direction, knowingly know that everybody's at a different state of affairs. The maturity varies across Canada on this topic of providing care services in both official languages or any other language of choice. So we went through these design principles of having a program that could address those needs, and it took us a few years to finalize it, and we've launched the first step of the program earlier this year. And really to address these barriers, to find a way to be innovative. And we're looking forward to learning from that to see if our bet is working, to really address those barriers, to make it easier and addressing those barriers so that we can all work collectively on this together. I would say outside of what we're currently doing at Accreditation Canada in partnership with many and Société en Français and others, there's I think another opportunity to reduce those barriers, and I think it was mentioned on the previous. I'm going to comment back on Jennifer Zellmer's talk from an hour or so ago. Is fostering that learning and sharing across Canada, and I would in fact say this conference in itself is exactly what I think is another incubator, lever for change, is that sharing across Canada. These best practices that are happening, the innovation, these ideas that are happening across ocean to ocean, finding ways to share those learnings as well to help early bottom-up approach for innovation and that sharing approach. And I would even challenge to make it a bit outside the box a little bit more, like previously mentioned, we're talking about access to French and English language here today. But there's perhaps even innovation in other language challenges, and to what Antoine pointed out, perhaps the Francophone discussions here can be the levers that the other minority groups don't have to help them move along their improved equity access for them as well. So that sharing, I think we need to think outside the box for the other, learning from others and sharing our learnings to others. And lastly, I'll leave to the thing that the technology in itself is perhaps the best way for incubation. I'm going to connect it back to the health human resource challenge that everybody has. We know that we can't make up new nurses. We know that we can't make up new doctors. We know, and all the roles are very sparse. And we know that we need to transform. And the only thing that points is better role definition changes, new process, and certainly technology. The fact we're having this conference virtually is one example, right? So can technology in itself be emphasized greater to help address these gaps? All the how and the best practice across Canada to be shared. So I think I really welcome these sessions like today to really foster that learning, these incubation hubs, these sharing opportunities for back to our program. What we're looking forward to learning to, as well as really thinking a different way to offer. And I'm happy in the Q&A session to answer more of the details of how to, if there's questions there, but thinking about a different way to offer it bottom up to really lower the resistance and barriers to adopting new programs. And I'll just leave on one point here that I think is also very important, because I'm a big fan of change management, and often we tend to jump to solutions That's the natural instinct of humans. We jump to solutions. But there's a very important step that needs to happen for change is before any solution, training, or skills or whatsoever is contemplated, the first step for change is really creating that awareness. And then usually the second step of change is the desire for change. So it's really important to make sure there's awareness and that clear. And back to that, I think right now we're in the perfect storm with this whole idea. Idea we use as an acronym for inclusiveness, access, equity, diversity. There's discussions occurring right now. So let's create that awareness. Let's mobilize, use that as a lever for change on awareness and continue through the change that needs to happen together collectively through Canada. I'll leave it to that. And I'm sure in the Q&A, there's probably going to be very specific questions on our OLRP program on how to, but I would say overall, we're happy to be partners, I would say, in this journey. And I would say there's no magic bullet, but the sharing and the panels like today will also help accentuate the collaboration across Canada beyond existing services. Thank you.
Well, thank you. I think that Antoine is really eager to reply because he's got his hand up. So I'll go to you.
I tried to be polite. I don't know if I can jump in line, but I really want to react on the change because I think that's. We all agree that things need to change and things need to change for the better. And there's just a lot of ideas out there on how to change things. How do you make change happen? And I think that's been one of the core experience from SSF over the last 20 years is we've really been building a proper way to implement change within health systems across Canada. And change needs to be incremental. Change is an iterative process. It doesn't start all at once. To change health systems, you first need to change people, convince people, right? You mentioned, Etienne, the first step is to know the problem and be aware of the problem. Well, that starts with individuals that plays their role within their systems and their power structures. But once these people are convinced, that change needs to move further along. The change needs to start being implemented into change requires often new capacity or new skills or new core competencies. And so change needs to move from a personal awareness to a building of new capacity within the health system. But even that building of capacity is not necessary to promote long-term change or sustainable change. It really needs to move then from capacity building into a proper real change in practices and a change in how services are delivered and a change in how things are organized. And so whilst the red tape is an issue, some tape, whatever the color, is needed in order to obtain long-term sustainable change within the health system. And I think that's one of the core challenges that we face. Because when you look at the roadmap or the ecosystem of healthcare, everyone is at a different scale in time, and there's a lot of decision made on a 4-year scale when a lot of other people make decisions on a 10-year scale or a 20-year scale. And so I think change is hard to happen because we have competing priorities within the health actors.
Merci.
Sorry if I jump in line.
No, that's okay. I was going to you anyway. So, Isabelle, what are your thoughts on this?
Merci, Gilles. So I think in terms of organizations' capacity to offer these French language services or equitable services, I think it stems from that strategic plan, and then it flows into, having those policies and actually living them, right? You don't just have it sitting there on your corporate website and say, okay, we have a designated bilingual positions. But do we actually do them? I don't know. We'd have to actually live them and follow through with them. And then when we start to hire into those designated bilingual positions, it's leveraging the broader community. I can't remember if it was Antoine or Étienne who said that, people work where they live. And so if we have French-speaking individuals in our communities, is to invite them to participate. So locally, we have Université de Saint-Boniface that offers healthcare aid, licensed practical nursing, and baccalaureate nursing programs in French. And so then that's a pool of individuals that we can then invite into the healthcare system and have them join the existing workforce for areas right in Western Canada. And I know in my fellow Western Canadian provinces, there are minority Francophone communities. And so it's about then seeing how we invite those individuals to come and join the healthcare system. I mean, Etienne, you said we can't create new nurses and new doctors, but, you know, I'm thinking in the future, I'm thinking the 10, 20-year plan that, you know, we can have these folks come and join. And also that these folks know that they can request services in French as well, or in whichever language that they would feel most comfortable to receive their health services in. So I think that's part of it. And so then making these links with these educational institutions, and for areas where there may not be those educational institutions locally, it's about making a link and highlighting that you know, a healthcare provider who's maybe considering working in an area that's less known to be Francophone, that if they are Francophone, that their resources would be valued. So I think that's the other piece, is to, you know, going to some of those pieces about culture and how it's tied, language is tied to our culture and to our values. We can also leverage those human services to you know, the human health services to provide the, you know, that link and that hook to have them join. The other thing I've been thinking about is, you know, that living, right? We were talking about not just having those tools and those pamphlets and that sort of thing when we're providing the health services, but having them as tools and then as a starting point for those conversations, so that we are having those safe conversations, that we aren't having an abbreviated, you know, you know, pre-surgery, here's what the risks are, and we have a very abbreviated conversation because there's a limitation because of language. So we really want to be using those as a starting point, and encouraging both our healthcare employees as well as the public to ask for those services, right? And you know, it's like that safe to ask, right? When promoting from, you know, healthcare excellence, right? It's safe to ask. It's safe to ask for services in French or another language. It's safe to ask for more information if we're not sure. And also from a healthcare provider perspective, it's safe to offer, and it's safe to say, I don't know, but I'll find someone who can help, because I think that's the other piece is. Sometimes people aren't sure that they can, you know, pause the conversation and ask for others to come and join. And so we think we can do it all, and truly we can't. We need a team to provide those services. So I think it's about incorporating that. So I think about, you know, that capacity to grow the capacity. I think that those are pieces that would help do that. And this is what I've heard from my colleagues locally who offer French language services in direct care, and having seen it when I'm out and about, you know, visiting other health services as a surveyor. So I'll leave it there.
Do you, question to everyone, do you think that linguistic profiles for a health authority would be an interesting tool to put together if they don't have it? And the reason why I'm asking is that there are quite a lot of anonymous bilingual people working in the health sector, just like any other sector. They've gone to immersion school. They might be from a Francophone descendants, but still, I mean, they have knowledge, they have skills, they have language skills. But I've heard of people working with co-workers for 20 years before realizing that they were both French, because they didn't have any accent. Either of them had any accent. They would notice me, of course, but not someone who was who's almost native speaker, but still have lots of skills. So what do you think about those linguistic profiles? Would that be a useful tool for health authorities? Anyone?
I think so. I know locally that's something that's done on hiring. New employees can voluntarily share if they speak other languages, you know, also share if they'd be willing to offer. We have more robust translation services available now, I'm really happy to say, but sometimes in the moment you might just need someone to come in and not do translation of health care information, but just, you know, please come this way, the bathroom is that way, right? Like very basic. So people are doing that, and I think it's helpful, and especially with our multicultural makeup. I mean, it makes sense. It makes sense. Yeah. So I know locally I've seen it, and I've seen it on my travels, but I'll let Antoine and Étienne comment on it as well.
Either
Yeah,
or?
I would say mostly a common practice for any language, right? But I remember back in my hospital days when we had the intercom, does anybody speak this language? Please contact. And then you had no, because back then we didn't have those repositories. But absolutely, I think leveraging existing resources within an organization to support services and from a linguistic point of view, I think that's it's becoming more and more a common approach by health authorities, as well as understanding where the demographics are growing from the services they provide to the population to be aligned from a service delivery point of view on these languages.
Antoine, any thoughts on that?
Well, I mean, obviously, I think linguistic profiles are helpful. I think that's been part of SSF activity for the last 5 years. But there's so a few ideas here. So first of all, being able to speak French is not always equated to being able to care or provide care in French, and I think it's this idea that language should definitely be seen as a professional skill, and that's something that is promoted, that is appreciated, that is compensated, and that is trained as much as possible. Because a lot of when we ask health professionals, would you like to be advertising yourself as a French-speaking dentist or doctor or nurse? A lot of people are afraid that because if you only do the profiling without doing the systemic adaptation needed, people are afraid it's just going to increase their workload. They're going to have the same workload they already have, but on top of this, they're going to be the person that gets referred to every French speaker within the clinic or within the hospital or within the center. And so profiling is important, but profiling needs to be done with the goal to provide better care and to better align the needs of the population with the capacity to provide care. And that links to my second idea, is that in order for this to work, you need to have a very good idea of where needs are. And to have a good idea of where needs are, we need better knowledge, we need better data, we need better collection of information. On Francophone, on every, I mentioned Francophone because that's the daily work, but I think with the bigger idea of this conversation, with every group that is facing some sort of intersectionality issue, more data means a better way to plan and means a better way to care, and ultimately more data will lead to better health outcomes. So as far as linguistic profiles, absolutely, but I think it's more about quality data on both capacity and on the needs.
Great. It's fascinating. Thank you very much for your answers. Now is the time to open the floor to question and answer with the public, with the audience. I don't know how technologically it works, but I'm sure that they will guide us. I don't know if people are able to ask questions verbally or I don't have a clue.
If you want, I can monitor the chat, Gilles. I can check the chat. Just check the hands up, and then we'll figure it out.
Okay, so I invite anyone who would have a question for our panelists to please use the chat. I guess that's how it's going to be working, and use the chat to ask any question. And
I see Mr. Stephen Trott with a question, hands up. So perhaps Stephen can just jump in, and if any people have questions, just mark them in the chat.
Please do.
Well, hello everyone. Thank you for taking my question. Oui, merci beaucoup pour une excellente discussion. I was wondering, Étienne, you had mentioned a literature review of different evidence around the impacts of the language barrier. I'm at the Saskatchewan Ministry of Health, so in the policy making side, building that awareness is really critical to, as we've discussed, building up the support within our health system to make some of these changes. So wondering, is that literature review or some of that evidence available on your website or
Yeah, so no, but it can easily be shared. So it was published by Bruyère Institute in Ottawa, but I can make sure through the conference that those interested can have access. It's essentially, it was not a piece of research itself, is knowing that there was a lot of research out there. So they did a PubMed search and a full scan, and they synthesized all the research on, and that was done I think in March this year. So it's a very recent scan. So they did it on a linguistic lens. It has a bit of a flavor for long-term care as well, but really focusing on language and equity. So we can make sure I can circle back with, well, first of all, somebody from the conference will reach out to me, given I just said that, but we're happy to point to where the research is.
That sounds fantastic. Thank you very much.
Thank you, Mr. Trapp. I think we have another person, Mr. Koch, John Koch, on stage 4. Hand was raised there.
Yes, yeah. So, yeah, I was in mute and hidden. Yeah, first of all, I would like to say it is a great opportunity to learn in this conference, and I can identify, like the previous panelists have said, I have multiple minority identity. I became Francophone, I would say Francophile. I learned French by loving it, and I'm still not totally fluent, but I come from a health domain and outside of Canada. And I was happy to see, because one of the problems we're struggling with at entity is that the capacity, we are there to advise and give recommendation, but at the same time, there's always a shortage. But the good news, I will start with the Société Santé en Français. When I was researching your website, when we got registered, I saw that you have project, that is Franco Santé, which is a good program that would work with the French student, a Francophone student at the institution of learning. I think it's a good, mine is a comment, but it's a question at the same time. So it's good to work in that direction, because the change gonna take some time. And I've been here in Canada for 24 years. And I saw that the health system in general is getting worse. The wait time and the shortage of doctors, but then it's even extra worse for the Francophone or any other linguistic minorities. So my question, I see there's a will, but is it not a time to put the politician to task? It's actually to overhaul the education system to target training for human resource for health. What pressure are we making? Because I know politicians would do action if that affect their election.
Who wants to dig in?
I know, Antoine, you're just burning to think of how to answer that. What I'll say is the following, is that lobbying from the top down has had little success on many topics over many years. And to your comment that you've not, and the way forward, so if there are provinces or regions that wish to proceed on an approach, I mean, I'll take it, and Antoine's role is mainly discussing with these people on a regular basis, it'll take some time and energy to go top down. But the important thing is there's perhaps other approaches too. And that's I think where we were struggling on the Accreditation Canada side a couple of years ago, to think, how can a program be built in a way that empowers, yes, top down, if an entity or organization wants to move forward, but how can it be, so we totally threw it out the window, say outside the box. Can it be bottom up? Can there just be one site? If they're ready, can they start? And really empower bottom-up approach and mobilizing the opportunity for change to occur on a smaller scale and to eventually percolate up at the same time if there's top-down approach. So your question's a good one. So we can certainly have these discussions top-down, and entails politicians, administrations. it usually takes time.
Mhm.
But the other, on the flip end, the open-ended question I'll challenge everyone, and it doesn't necessarily always have to be with the Accreditation Canada program. Are there others options for incubation of a bottom-up approach to start the change? And I'll just call it out. We just lived it through COVID. Using technology to do things differently at the local side, the repeated, like healthcare, I'll show you, this is a 10-year-old stat, it's probably old but relevant, is on average, mind you, this was 10 years ago, innovation took 20 years to be implemented in healthcare. So that's scary. Innovation, 20 years to implement in healthcare. Mind you, recently we changed those stats because of COVID. We were able to innovate in digital. How did that happen? It happened the bottom-up approach, the ideas, the generation. So what I want to get to my comment is there's usually these two approaches, the top-down and the bottom-up. And so I really encourage people to share across Canada, because those incubation, those innovation hubs, the bottom-up approach can act as incubators for creating awareness of an idea, but also proof as we say, proof is in the pudding, the outcomes, like Antoine mentioned about. So if a bottom-up approach can encourage that change at the local level, for there to be visibility and others to be aware of that and to help mobilize further down. So I envision there's two approaches to this, and there's a top down, and maybe that's where I let Antoine comment on, has its process, but it requires a lot of energy and a lot of work to really focus on the top down approach. Antoine, what are your thoughts?
Yeah. Thank you, Etienne, for giving me time to organize my thoughts on that one. That was good. Okay, so the way I answer your question is by everyone reacts to incentives and the structure in which their work revolve around. So I think it's easy to look at politicians, and I'll be the first one to do it, and be like, well, you should make better decisions and we should think long term. But we have to acknowledge that we have a system that promotes at the political level short-term thinking in order, and you mentioned, in order often to, with the time perspective of the next election. But exactly as Etienne's point, like there's obstacles at every level, and there's people to be convinced at every level. And I think there's one incentive that every health partners, whether a government, whether health professionals, a health manager, even communities or training institution, there's one incentive we all have. And I really, really believe that this is a guiding principle for everyone. We want to give better care to everyone. Everyone involved in healthcare aims to provide quality care for others, just basically help out. It's a tough job to work in healthcare, and people still choose to do that job and I really think it comes from a place of wanting to help. So yeah, I think change is, it goes back to change. Change is really tough to happen. Change can take time, but as we saw in the COVID pandemic, forced change is definitely possible. And then, in the short term, and then we're going to adjust. But then we also saw that with the pandemic change, it created a whole other bunch of issues regarding equity or access to services or how people react to it. And so, yeah, I think your question is a good one, and it needs to start. If we want to change things on a long term in a sustainable way, everyone needs to be involved in that, and everyone needs to see the common objective. And the common objective, and I'll go back to it, should be population health. It should be health outcomes. It shouldn't be metrics within like how many services are delivered. It really should be, does what we do work? Does it help people? And does it make Canadians, regardless of their characteristic, regardless of their situation, regardless in all of their diversity, are Canadians in better health thanks to investment? And I think that should be the guiding principle. I hope it helps, John.
Thank you.
Isabelle, your thoughts on that?
Well, I think that there are some pieces happening, and for example, I'm more familiar with the local context in Manitoba, but for example, opening up the number of seats for different healthcare programs, right? So the number of nursing seats and other healthcare training that's available provincially. There, we've seen an inclusion of that. We've also seen a strategy where nursing students in particular are being able to work on the units as I don't know what the exact title is, but they're still students and they're still going through their program, but they're available and they're getting clinical experience and being available and as part of the team. And so they are employed and they're doing this work concurrently. So these are some strategies, again, that are new given the context of COVID and the immense pressures that it's put on our healthcare system, but we're seeing some interesting pieces come in. I think burnout is going to be something that we all need to look at you know, not stop because people are leaving. They're leaving either the profession, they're leaving the areas, and so we would need to be mindful of that. But certainly there are some strategies that are coming, and also from the ground up, right? I agree. It's, you know, top down, ground up, because the healthcare employees, they're asking for help, and the public is being extremely reasonable and supportive, and saying we need more, right? And help these people out. So we appreciate that. Yeah. I did notice a question in the chat about how do we, even if you have bilingual positions with the shortage of staff, how do you ensure that quality services are offered in the language of the person's choice 24/7 and 7 days a week? And that's a great question. And I can speak just from personal experience and what I've seen. And I think it's leveraging the larger family context, if you will. So really looking at our clients or patients and their who they determine to be family, and bringing them into the fold, as well as we may not be able to offer a bilingual care provider 24/7, but ensuring that the key pieces are being offered in French or in the language of their choice is really important, right? So we may not have someone available all the time, but if we're getting, you know, a consent form signed, let's make sure we have a proper, you know, someone with the training to offer the proper language, you know, so that the person is getting an informed decision. So that's just something that we've encountered, and I've seen it on my travels as well. So yeah.
I'm looking for the digital hand and I don't know where it is. So I'm just putting my real hand up.
That's a real hand. I gotcha.
Isabelle, really good point. And that's where I'll point out where the standard can help. So if we reflect, the standard was designed it took a few years to develop the standard for reflections to happen on the criteria. So alongside, and every used context in every scenario across the world will be different, but being assessed or reflecting against the standard really helps reflect on and not forgetting important items, and especially when at the break point where there's the most risk. So when when the staff are tired, we have all the perfect storm happening. And so finding an easy way to reflect against the standard to make sure the risky areas are addressed. Will it be the perfect way? Not always optimal, but just to make sure we're not forgetful about the criteria that were designed through the standard. So alignment with what you mentioned, Isabelle, to answer that question, I would also say that reflection against the standards is also there to be helpful, because it's easy to forget one key item when we're looking at this picture. And sometimes that standards be there to support that reflection, I would say. And it's knowing that it's not going to be perfect, but just having that reflection to be aware against all these criteria to say, where are we okay? Where do we need to focus on? Where, you know, to help structure this a little bit more, because with no structure, it's easy to spin and it's easy to forget maybe one thing that would have been very critical if it would not have been captured through the reflection process. I just want to point out that the standard, but also the assessment programs underneath that helps support that structure for some reflections.
Great. Antoine, 2 minutes.
I'll be very brief. I know I'm aware of the time. I saw this question as well, and I think how we frame the objective really matters here. Because if we frame the objective of like having bilingual services 24/7 everywhere all the time, I don't think we have that in English at all right now. Like that's not even something that exists in healthcare right now in Canada. There are publics. There's some specific groups that have higher needs than others. We mentioned seniors earlier, mental health was mentioned, children, youth. There's a whole bunch of people that have, like, not every service is equal in importance. We are able to prioritize. We are able to focus on the areas that we think will generate the most health outcomes or improve health outcomes the most. I'd say the first step would be, let's start first having bilingual GPs for every francophones as a starter, and then after this we can maybe consider the 24/7. But like, we are able to prioritize, and we should, based on what helps the most in this current time. Thank you.
Well, great. I guess that we're close to the end of our session. I'd like to thanks member of the panels for your excellent thoughts, and I think that it was a very useful discussion from the comments that we could see on the chat line. I think people really appreciate it. I certainly didn't have a tough time to have you talk, and this is always very nice for someone who's trying to create content and to have people share their thoughts. So thank you very much for your participation, and